Hello, my name is Rachel James, and today I, Michael Mattheis, and Doug Mayne will present to you the following data analytics project: Exploration of Air Quality Impacts on Asthma Diagnoses. This project stems from the observation that in Houston, Texas, there is a major pollution problem. There's poor air quality there, and we wanted to explore the relationship between air quality and respiratory illness, specifically asthma. So we decided to look at the years 2005 through 2009 and the Harris County, Texas area and determine what the relationships are between pollution levels, pollutants in the air, and diagnoses of asthma.
Hello, my name is Doug Mayne. Next, I will be discussing preparation of the air quality data for use on the project. Later, I will be discussing our linear regression model, the model results, as well as the challenges and changes to our overall project vision. Our project followed the CRISP-DM model, including data preparation, with the steps for data gathering, data consolidation, data cleaning, data transformation, and data reduction. Air quality data is available from a broad variety of sites, including AirNow and other online data collections, the Texas Commission for Environmental Quality, the Center for Disease Control, and the United States Environmental Protection Agency. We decided to use the EPA data due to the consistent quality and ready availability of the data over the time period we were looking for. Cleaning and transformation of the air quality data was a fairly straightforward process. The U.S. federal government has strict requirements for the recording, reporting, and storage of air quality data. Because of this, there were multiple data values for each category, allowing us to evaluate which ones are best to use. Location data included GPS, state, city, county, zip code, and physical address. The pollutant recordings themselves included daily maximum values, averages over an 8 and 24-hour period, as well as a calculated air quality index for each pollutant over the entire time period from 2005 to 2009. There were almost no missing values, and the data recorded was of a consistent quality, format, and type, meaning a zip code as a 5-digit integer in 2005 was still a 5-digit integer in 2009. There were a small number of error reads from the air quality machines, however these were clearly labeled, allowing us to evaluate them and maintain the integrity of the data overall. One thing we noticed was a high degree of correlation between the pollutant recordings, including the raw reading, the daily max average, and the air quality index. They all had an absolute value of R greater than 99%, indicating that these data values were the same. The final step of data preparation for air quality was data reduction. This was a significant undertaking due to the sheer volume of data that is available. Each pollutant had 30 parameter readings daily per each reading site across North America, including the 48 contiguous states, parts of Canada, Mexico, and the Caribbean. In reducing this data, we cut the 30 parameters per pollutant down to 3: a date, a location, and an air quality index. The 5 years of daily readings were reduced to 20 quarterly values to match the way data was presented from the medical side. The readings for all U.S. sites in North America were reduced to Harris County, Texas. Date, location, and AQI allowed us to do this.
Hi, my name is Michael Mattheis, and on the next series of slides I'll be discussing the data preparedness involved with the health data as it relates to our overall project. Additionally, later on you'll hear me discussing the decision tree model and the results of our analysis with that.
Continuing with the discussion of the data preparation, for the health data, we contacted the Department of State Health Services at Texas and was directed to a collection of text files that was publicly available that contained discharge counts of patients and some demographic information, as well as some health-related information in terms of the ICD-9 codes. And from this, we were comfortable moving forward with our analysis. In terms of data preparation for the health data, we chose to combine or consolidate our healthcare data with a file of zip codes contained within a specific county of our interest. And so this combination of data allowed us to reduce the data down to a very specific set that we cared about. In terms of data cleansing, we only had to worry about records where there were null values, either for the patient zip codes or for the admitting diagnosis code. And these represented a small minority of the overall data set. In terms of transformation of data for the health data, we did run into the situation where our zip codes were of different data types between the zip codes of our focus area of Harris County, Texas, and then the format of the zip codes in the health data. This did not represent a very complex issue at all. And lastly, in terms of data reduction, as I mentioned earlier, we were able to just use filters in the form of the SQL where clause to filter out data that was missing either zip codes or the admitting diagnosis code, the ICD-9 code for asthma. And then, of course, we used aggregation to count up the number of asthma patients for the quarter by zip code.
One model type we knew we wanted to try was a linear regression model. All of our data was numeric and fairly clean, and a linear regression model was a good way to analyze numeric data. The first thing to do when building a linear regression model is to check that your data fits the requirements. There are 5 requirements. First, you check linearity and multicollinearity. Then you build a first test model, and using that model, check for homoscedasticity, independent residuals, and normally distributed residuals. Linearity can be checked by a simple graphical observation. Here we have 2 graphs showing the count of ICD-9 493 asthma codes versus 2 pollutants, carbon monoxide and sulfur dioxide. As you can see, each of these pollutants has a linear positive relationship between the pollutant level and the incidence rate of the ICD-9 code for asthma. Next, we checked that the independent variables were not collinear. We chose a 0.80 limit, which is fairly relaxed. However, with the quantity of data and the degree of manipulation we had performed on it, we decided this was a reasonable value. The first pass showed a strong collinearity between the PM10 and PM25 pollutants. We went back, removed the PM25 data, and reran the correlation. This time, we showed no collinear relationships between the independent variables. The next 3 linear regression checks require a model to be generated first. Using our software, we created this equation, which describes the expected number of 493 diagnoses for asthma as expressed using the air quality index of carbon monoxide, nitrogen dioxide, ozone, PM10, and sulfur dioxide. We conducted a second test for collinearity using the model by finding the variable inflation factor. Our cutoff was moderately conservative target of 5. The VIF reported back to us was 4.05, which was within our range. The third check is that residuals are homoscedastic, meaning they have constant variance when plotted. The graph here shows we have fairly constant variance of the residuals.
Our second model of choice is the neural network. We decided to use IBM Modeler to put together this model. The first time we put together the neural network, we used a 70-30 split between training and testing. And we found that the leading predictors of asthma diagnoses count were particulate matter 2.5 and sulfur dioxide. This seemed rather sensible since particulate matter 2.5 involves a multitude of tiny particles in the air that exist both indoors and outdoors. And then sulfur dioxide results from burning coal, which is done in Houston, Texas, to produce electricity. So that seemed like a rather sensible result, but we did pursue a second iteration, this time an 80-20 split between training and testing, and leading predictors were the same. So this told us that splitting the data wasn't necessarily going to impact the result of our model. However, as you can see with the neural network, we don't arrive at any quantifiable result here. So when we compare this model to linear regression has the upper hand because regression provided us with an equation that we could use to predict future values. The neural network simply tells us which explanatory variables are most impactful towards the target variable, asthma diagnoses count. So later we'll discuss which model of the three was ideal for our project, and in this evaluation we certainly looked at the disadvantage within the neural network with its lack of explicability and the fact that we didn't obtain anything quantifiable from the neural network model.
To conclude our discussion of the model building portion of our analysis, we looked at the decision tree model primarily because it was simple to build, it was easy to understand, and it would give us a quick result to include in our analysis. We realized going in that the decision tree model is best suited for categorical data, and understanding that our data was continuous. We didn't have high expectations, but we did learn some things from the decision tree, and one of the first considerations that we realized was that the leftmost column in our data set needed to be our target variable, which in our case was the asthma counts. The resulting decision tree indicates that the initial split occurs on the ozone air quality index reading, and that value is, in this representation, 33.395. So the second split on the left, if the reading is less than that, is the sulfur dioxide air quality index of 11.28. And according to this model, when the ozone AQI was less than 33.395 and the sulfur dioxide AQI was greater than 11.2801, we predicted, this model predicts, that we will have the highest number of asthma-related hospitalizations at 594 per quarter. On the other side of the model, when the ozone AQI is greater than 33.395 and the particulate matter less than 10 microns is greater than 28.3711, we noticed or are predicting the fewest number of asthma-related hospitalizations at 384.6.
Our original project vision was to demonstrate the correlation between air quality and respiratory events in South Texas, in Harris County, and in the greater Houston metropolitan area. We then wanted to overlay that correlation to an indoor smoking ban, which was passed in Houston in September of 2007. Thus, our project expected to demonstrate the correlation of air quality and respiratory events plus the change that a major metropolitan area would have by the passage of an indoor smoking ban. We could then use this correlation to project onto other major cities, or really cities of any size, the value of improved air quality and the passage of indoor smoking regulations. Over the course of the project, the team faced several significant challenges that changed the direction of the project itself. The first was the large quantities of air quality and medical data exceeded the processing capacity of the team's computers. In order to deal with this type of information, we would need to move to a cloud-based or server-based system to deal with the quantity of data. Additionally, we didn't realize there was a high cost to access quality medical data that we were expecting to use. Many of the places that offer this medical data had subscription costs in the thousands of dollars, which were not within the reach of the team. Additionally, the HIPAA Act of 1996 stripped much of the personal information, including dates, times, locations, and specifics of diagnoses, in order to protect the privacy of individual patients. Our unfamiliarity with the medical data overall also led us to choose only the Asthma ICD 493 code when there were probably other respiratory codes that we could have used that would have lent themselves to our model. The results of these challenges meant the project team spent more time gathering and processing air quality and particularly medical data than originally expected. We were unable to access some parts of the medical data, such as diagnostic codes, locations, and times, that we had originally expected. This led to a mismatch between the air quality data and the medical data. For example, air quality data was available daily from multiple locations with specific addresses, whereas medical data was available only quarterly by region. The project team was unable to demonstrate a correlation between the Houston, Texas indoor smoking ban and the respiratory diagnoses. The data simply didn't support that type of correlation. However, the project was successful in its original mission to demonstrate a correlation between Harris County air quality and Harris County asthma diagnoses.
So, in wrapping up our presentation, I'd like to just take the time to discuss some of our lessons learned from this project. The first one being the need to aggregate and classify data early on, specifically when the data comes from various sources. So we had one source for our medical data and one source for our air quality data, and we could have benefited from really getting our hands dirty with the data earlier on in the project timeline. The second lessons learned is accepting the fact that it may take longer than anticipated to collect the data that'll help us address our initial goal. So as Doug alluded to, we originally wanted to take a glance at maybe exploring the relationship between the smoking ban in 2007 in Houston and its impacts on air quality and therefore health data, but that's not an angle that we were able to pursue, and so accepting that earlier on would have been helpful. And lastly, realizing that with a specific timeline, we've got to be flexible. And I think we did a good job of executing that, so in the future, facing projects like this one, we'll certainly do the same. In conclusion, we certainly enjoyed taking on this project, and we're pleased that we were able to meet our goals. Thank you.